talk a bit about management of bone defects. So I think I gave away my hand in my first talk recently. You can imagine in these options, prosthetic, allograft, or cable, I'm going to go towards the biologic, whichever one that gives that option more. So generally in orthopedics, we like to say we heal with steel, right? And we do. I mean, we use steel to heal, but you know, my oncology colleagues love metal implants. And so as I showed earlier, this is a very typical type of reconstruction. It's compressed, it's biological in a certain sense. For those of you who don't know this, that is a spindle at the top portion of the implant that is anchored into the bone, and then this is a hydroxyapatite coated, a porous metal that essentially is compressed into the distal femur or tibia or anywhere, and it achieves very good long-term stability. So it's biologic in a certain sense, but like most things, it works until it doesn't. And then you begin I remember in vascular surgery as an intern, I can't remember the name, but it was like, there was like the fem pop, then it was like pop, then it was all the pops until it was like chop, right? and this is like, unfortunately, this is the orthopedic version of that, where, one thing breaks and then, all right, now we've got we got a bigger metal body. We're going to get most of that stuff out, and we got a good, press fit stem until that breaks. And now you're starting to see signs of loosening, and, he's probably infected, even if he's not, doesn't appear to be infected. So now we got more metal, cement that in. Of course, I think taking that out, you get a breach in the canal because, that's what happens when you do these things. And then of course, eventually that gets loose. As I say, this is why I don't like cement. And then eventually the guy, what do you do now? What are your options for him? So there's a very high opposite of biological metal and allograft reconstructions. Unfortunately, their success starts to drop over time. Especially the bigger the prosthetic, the more these mega prostheses, things like infection, revisions, and all these things have so much higher complications. Back to exactly what was just said. I think that osteointegrated devices, I think, will change that. Again, so I don't like metal, as you can hear. I don't like allografts that much either. This is an allograft in a distal femur. Intercalary, there's a vascularized fibula in the middle, which should help to heal. But of course it doesn't. You can see a non-union here, treated multiple times, dual plates, bone grafting, again, probably infected. Don't criticize too much. They always say just cover the top and the bottom, and as long as the joints are aligned, that's all that matters. But yeah, so, and this is absolutely from a proximal tibia fracture after quadriceps plasty and manipulation, where I got a proximal tibia fracture. So I say I create my own complications. So I don't like allografts because they often have to be revised. And again, this is a young kid. Eventually, once you get to this, he's done. Thank God. He's bone marrow model. He doesn't have any issues, and I haven't had to see him in years, even despite all of this stuff. So, there's a phrase that I learned, I think, at some point in actually fellowship from Dr. Herzenberg, which was, if you think you came up with something in orthopedics, it's because you don't read German. And then I learned a variation on it during my, I learned a variation on it. I won't tell the full story from Dr. Rosberg, but I learned a variation on it from Dr. Rosberg. When you think you've thought of something new, it's because you haven't read enough, like his textbook, or you don't read Japanese. So it's a longer story, which I wouldn't embarrass myself with. So everything that I've been talking about is all from Dr. Tsuchiya. So much of it is from Dr. Tsuchiya, who's laid the groundwork after diligent years and years of effort publishing. This is the culmination of it, but just many, many articles showing the success of XFix, the risk of infections, all the other stuff that can be handled. And, when you ask Dr. Tsuchiya for a picture of himself, this is what he sent me. I kid you not. So, if you ever have a chance to see a talk from Dr. Tsuchiya, you should absolutely, even if you have no interest in the topic, because he has these caricatures flying all over the screen, dropping bombs on tumors and lengthening bone. And every person in his lab has a caricature of him, and he uses them all the time. It's amazing. So the thing about the biological experience is this is the summary, is look at how well they do over time, and there's no drop off over time, and that's the most important thing. So, he likes to point out the fact that they only get better and better. Eventually I did find another picture of him, which is almost as weird, and then eventually I found a real picture of him. So this is Dr. Tsuchiya, and I had the honor to go and work with him. Sorry, learn from him is a much better way of saying that, in Japan for a couple of weeks. I know that you're going over there. I think that's awesome. I think it's a really interesting experience to do that. So, just because we can put a metal in, just because we can't put an allograft, or maybe I would even say just because I can do a biological, is that what we should do? Just because we can doesn't. Problem is, not the problem. The good news is that our patients are surviving now. So chemotherapy is consistent enough, and it's only going to get better, that patients are outliving, and more importantly, they're outliving their reconstructions. They're not just outliving their cancer, they're outliving their implants. And I think we all know that, unfortunately, the younger you implant these huge megaprostheses, the less they last, right? So it's almost a counterproductive process. The impetus behind all of that is this, but it's not that biological reconstructions don't have, obviously, their failures. So one of the problems that I deal with often is the chemotherapy, and we know that there's a question about how much the chemotherapy inhibits bone formation. There's also some evidence, not great evidence yet, that shows that actually the one thing that might combat the inhibition of bone growth is actually distraction osteogenesis, because there's some good studies showing bone scans, during chemotherapy, the increase in activity during distraction. But it doesn't mean that we don't get our fair share of problems. So I prefer, as this topic said, how do I deal with my defects? I deal with a lot with biologicals. So one of the things that we get around with these huge tumor defects is we try and find ways to make that time less. So I talked briefly last time about acute segment transport. Here's an example of that, where we have a neck and a greater choke over here. You can't see it. So we take a small segment from here, put it up there, so I have enough fixation now that I don't have to go up into the head or anywhere too scary, and I have a good, good fixation. Again, this segment, again, I subtly won't notice this, but this cable used to be intramedullary, and that works. I used to do both intramedullary until this happened, and you see how much tension there is, and it broke through the lateral aspect of that shaft. So now I put one intramedullary and one extramedullary, and now I start putting holes in these pins, actually, and I pass the cables through the pins, a 2mm hole with a high-speed burr, and you can put a 1.8 and 1.5 millimeter wire right through that. So we do acute segment to try to and soft tissue, so now I can reattach the lesser to the periosteum, and I think in this one you'll see over time that the body is able to, once again, biology is awesome. I always do multiple drill hole corticotomies. I don't use a giggly saw. I don't use high-speed burrs. I guess it's just preference. I said I do one intra and one extra because of that problem. I also do a temporary unicortical half pin. This might be overkill, and my PA always worked with for a long time keeps telling me I don't need this anymore, but she's probably right. I put it in for the first 2 weeks. This one for 3 weeks, excuse me, and this one for a little longer than that, 5 weeks usually, just to guide it so that nothing gets separated too far or too quickly. Sorry, that's the half pin there. So you see over time, and the advantage of this is if I have one segment that's not making good regenerate, I can just keep pulling the other segment up, and then I don't have to worry about it. So this segment made great regenerate, this one didn't as much, so I can just take advantage of that. And I've always bone graft the docking site. I think everybody does. I said I BMAC the regenerate sites. And this looks like a torture device. This is skin wires. These are transverse skin wires in a very large tibial defect for an adamantinoma. So you have 20-something centimeter resection. The skin will invaginate over time, and I put in these 1.5 wires across about every 1.5 centimeters, so that every time they come to the office, I can pull them out. I've tried this with suture. Somebody told me you can just do it with like a thicker suture, but that eroded through the skin. And so I had to go back and did it with the wires, and that worked better. I also have, I think Joe Su told me that you can do it with a suture attached to the end of this, kind of like the cable is, and coming out. I've not been bold enough to try that because this works, even though it leaves a lot of scars, it works really well. But I'm certainly open to other ideas. Like I said, patients don't like the look of it. Again, acute transport is my new best friend. No matter where it is, I can take, what it is, I can take a segment. So here's this is a chondrosarcoma, really weird. 10-year-old kid with a chondrosarcoma is extremely rare. So chondrosarcoma is here. Then there was this other abnormality here, which once again, my radiologist couldn't tell me what it was. You can see the bone was slightly abnormal there. And so I had to resect that as well. So it's a decent sized defect plus margins. So we get up to the level of the lesser, essentially. That's my planned osteotomy. That's what would be the resection. That's my acute segment. I move it up, and I have that here. And what's interesting in this one is young enough that we reattach the lesser apophysis to this, and the periosteum remodels over time. You guys know how this works. And look at that. Look at this little apophysis over here that just forms on its own. And that's fascinating to me, like actually fascinating. And then, thankfully, it becomes solid bone. Yes, it requires a conversion to an internal because no one wants to wear an X-fix that long. Here's that thing. And then thankfully, ultimately, he does well. His distal physis, ironically enough, didn't grow fully, and he had some residual deformity, so I was happy to get another crack at him and lengthen him. I corrected some of that residual deformity. Again, those are techniques we talked about. Blocking screws are my second best favorite friend. So he's doing well. Somebody asked me on the break if I ever do if I do these during chemo. The answer is I do now, because for a while, about the first year of my practice here, I did a temporary spacer. I would do the acute segment transport, bone graft this area, reattach the extensor mechanism, which I think is the most important part of this, because as we all know, with proximal tibia replacements, the reattachment of the extensor is not good in metal or anything that I know of, other than even allografts. They don't work, they stretch, they fail. The only thing that works well is biologically. So we reattach that acutely. I thought, 6 months later, they get chemo, this will heal, and it does. And then I come back and do the transport. It's a simpler transport, and just move it up into there. And I put them with a big spacer. The short answer is what we found, and I guess believing Suchiya even more, that the risk of infection was not any worse doing this during chemo. And so I do it now during chemo, because otherwise I'm just prolonging the torture for these patients and their families, right? Because you get 6 months or 9 months of chemo if it's Ewing, and then you're going to start a reconstruction, and that's just, at least now I can blame, but now when they feel miserable, I can blame it on the chemo. And not on the fact that everything else I'm doing to them. So this is that same girl, and I don't have a newest update, but I was able to get these screws out. And this is the segment that I think is the one that didn't heal. The lateral side, ironically enough, did. It was more this corner didn't heal. You can even tell it's kind of isolated all around it compared to the rest of it, which looks good. Eventually just removing some of this, and with these screws and with time, it did heal. She has very good function, and so that's her extensor mechanism, and that's something that is important again for the long term for these people. So it's not that I never use an allograft. Sometimes I have to. Unfortunately, I can't preserve the distal or proximal articular surface, and so that's the best indication, in my opinion. As Dr. Rosberg was asking, Suchiya has done this, either partial or full articular surface allografts. This is a 13-year-old with a distal femur. This was earlier in my career. He does have extension of the tumor down to here, and so this is certainly questionable. I would have now I probably would have spared the lateral condyle, and I would have done a hemiarticular allograft. I just think the less allograft you have, the better, but this was earlier on, so this is a full allograft now. The entire distal articular surface is an allograft, and this is a precise, and I apologize, I don't know, somebody recently presented at one of our meetings using a precise nail for intercalary allograft compression and getting really good results, getting those to unite. And I think that's certainly a novel and good use of it. In this case, I used it again in my term, the bone stock, trying to restore bone stock. So taking this segment and transporting down into the distal allograft. And I think the larger surface area, I think that the biology of the distraction induces an amazing healing response and to these allografts. So in all of the cases that I've done this in, I've not had a single non-union of my allograft, which is remarkable because that's the biggest problem we have with allografts. And so if you look over time, it not only does it heal here, which is what we usually get, it heals all the way along here. It's healed. This segments get pushed into there. And I wasn't sure what was going to happen with this, but it's actually kind of interesting. So it almost looks like it is expanded. And I don't know if anybody has any thought about what's going on biologically here, but I pulled up for you guys, I pulled up the CT. So this is with the nail in place. And I want to show you what's happened is that the transport segment has expanded to fill the entire allograft and even beyond of what's the allograft. So it almost fills the cancellous medullary space. And you see that's initially where the allograft ended. Where the transport segment ended, that's all allograft. And now this is of an MRI, so it's a little bit different, but all of this is normal marrow fat that I assure you is continuous with his normal marrow proximally. And I don't understand it, it's not cancer, but if you see the only part, this is the allograft, and it's very different on signal, and my radiologists have confirmed this. I don't know what's going on here. I think it's something I'd like to know more, but maybe somebody here has a clue. But it looks like it's sort of grown out, and this edge of sclerotic bone is his bone. I think the allograft's still there, but I'd like to, eventually, when the allograft fails, and I say when because it will, we'll have to figure. We've got to look at it. And then the last thing, again, I do use metal sometimes, but I try not to use it very often. And this is one I would really like some feedback on. I said it earlier. This is a 16-year-old, very athletic girl who had a right proximal femur Ewing sarcoma, very close in her neck and in her head. I was able to initially save her head. Again, very similar to the one I showed earlier, but I used the proximal femur locking plate, which I do not like. I would not use. I didn't have enough room here to do everything I wanted to do. I did an acute shortening, a transport, and then I did a nail for lengthening. So this is initially my plan. This is a little bit better. The idea with this is, okay, I'm going to put the plate in, then I'm going to use the plate to squash it down, and I'm going to, there it is, to get realignment, and I'll have a plate and a nail spanning the defect. It'll be stronger, allow her to weight bear earlier. And then you can start to slowly seal that this neck, whatever, whatever you want, I don't know what that is, subcapital junction never really healed, and then it failed completely, and I had to go back and revise her, and I switched her to this. And this, what's interesting about this device, and I'm not, again, I'd like to know what y'all think. This is an extremely strong implant. And what you notice about her regenerative, it only forms on the medial side. It doesn't even form on the lateral side. And this is like a year later. But her bigger problem is that her head neck junction never heals. And so even though the head seemed viable on imaging and she was functional and everything else, she obviously collapses. She eventually breaks through into the articular surface. So I have to go back in. The head was not viable, unfortunately. And the articular surface didn't look great. And as much as I really want, it feels like a loss, right? I wanted to keep the head. I was able to, at least, her other option would have been a proximal femur replacement, you know, where we would have lost the greater troch attachments, as I mentioned earlier, and the bone. So I still think it's like, it feels like, you know, silver place at the Olympics, which I heard a podcast that people who get silver place have more higher rates of depression than the people who get bronze medal at the Olympics, because they're like so close to the gold. And so this is, and I'm not my problem is I'm not a joints guy. I mean, I'm not like a joints nerd. And so I don't know enough about joints, and I probably should consult people more about this kind of thing. So after we found her head was dead intraoperatively, I switched her to this type of a porous stem, but she's subsided a bit, and I don't know if I should have used a different stem. Should I have used a longer stem with a proximal, like, modular body? My thought is always I want to minimize the amount of implant metal I have in there. Should I have done a total on a 16-year-old? I think some people would say yes. Some people would say no. I don't know. I got like mixed reviews. I'm very curious to see what you guys would think about it. She's subsided, but she's stable. Again, I'm actually genuinely asking for advice. Thanks.